Well, I'm Chris Wheeler. I recognize a few faces. I've been here at Access for 15 years. I'm a PA. I work a lot with Dr. Josh Siegel. Work with a lot of the docs. But in my 15 years, I've done everything from hip and knee replacements, assisting with some of the old surgeons, to injection therapies, to referrals for rehab. So I like to think I have a pretty good sense of arthritis. But every time I think I have a pretty good sense of arthritis, I come out with something new. So my goal tonight is just to give you sort of a background of arthritis, so to understand the path of not go into great detail about what happens, but if you have arthritis, it's nice to know what causes it. Everyone says, oh, it's arthritis. Well, what does that mean? We'll go through that, and then I want to talk mainly about non-surgical treatments for arthritis, because there's a whole gamut of different treatments that can be done for arthritic pain. And mainly we're covering knee arthritis this evening. I think arthritis is such a huge topic that we just tried to pare it down this evening to talk about knee arthritis. And some of the things that we talk about with knee arthritis can go through with other types of arthritis as well. So just a little humor to get started. So again, who knows what arthritis is? What are joints and why do we have them? That might be a very simple question, but why do we have joints? What makes up a joint? What would your life be without joints? Could you write? Could you jump? Could you do all of the activities that you do with daily living without joints? No. And there's several different types of joints in your body. You've got actually have joints in your head. You've got joints all throughout your body. And the ones that move your body are called synovial joints. And the reason we talk about synovial joints is because those are the ones that get affected by osteoarthritis. Again, do you know anyone who has arthritis? I'm sure many of you being here know that yourselves may have arthritis, or family members have arthritis, and you know how it can affect your life, and it can. And if we can come out of this with learning one or two things to help with that arthritic pain, I think that'll go a long way. So arthritis is this sort of global term. Arthritis, you break it down, it goes arthro and itis. Arthro means joint, itis means inflammation. So basically arthritis means there's an inflammation of the joint. With osteoarthritis, which is what we're talking about tonight, being the most common, you can have rheumatoid arthritis, you can have psoriatic arthritis, infectious arthritis, non-infectious, so there's a gouty arthritis, pseudo-gouty arthritis, psoriatic. So there's a lot of different things that can affect the joint, but what we're talking about tonight is osteoarthritis. So this is a basic synovial joint. This is what a synovial joint, whether it's your wrist, your shoulder, your hip, might look like. And they're neat structures. You've got the cartilage, which most people, that's the cartilage, that smooth surface on the end of each bone that allows the joint to move. It's kind of like taking two pieces of ice that float together and go together smoothly. But that's not all that's affected in arthritis, so that's why I thought it was a good idea just to give you a basic understanding of what a synovial joint is. You've got the arthritis, you've got the cartilage, you've got synovial fluid, and as we get into the talk, we'll see how synovial fluid can affect arthritis, or how some treatments with synovial fluid can help. Oh, that's all right. Can help with arthritic pain. You've got the bone, obviously, involved, and there are changes that occur in the bone that help or that affect arthritis. There's changes with the ligaments. The ligaments are the connections between the bone that hold the bone together. And you have the synovium, which is actually a lining around the bone. If anyone's ever seen someone with a big swollen knee, the synovium is the covering over that knee that produces the synovial fluid that bathes the joint. So you've got a lot of moving parts inside a synovial joint, not only just the cartilage, but all those other parts that can be affected with osteoarthritis. So again, definition of osteoarthritis: disease characterized by degeneration of cartilage and its underlying bone within the joint. And you may also know this is also called degenerative joint disease. So in a normal healthy, so this can happen in any synovial joint, but in a normal healthy joint you have nice smooth cartilage. In a arthritic joint, you lose that cartilage. whether you might get divots in the cartilage, it may fray, it may peel off in sheaths, but basically the normal cartilage is worn away gradually over time, and exposed bone is then what's rubbing. So instead of taking nice pieces of ice and rubbing them over each other, you can take sandpaper and gravel and rubbing it over each other so it becomes less of a smooth surface. And there are a lot of other changes that occur within the joint and what we'll go through as we go along. So this is sort of, okay, we looked at a healthy joint here on the left, and that's what we looked at 2 slides ago. And now we're looking at sort of a arthritic joint, or what might occur in an arthritic joint, not only just with cartilage loss, but with, so again, to review the normal joint, you've got the nice ligament, you've got the synovium, you've got thick synovial fluid. So in a normal joint, you also have this fluid called synovial fluid, which is kind of like motor oil, and it bathes the joint and lubricates the joint, very viscous, and helps to cushion that joint. I'm going to sneak over here. Now in an arthritic joint, we talked about how you get destruction of cartilage. As that cartilage gets destroyed, the ligaments begin to loosen, and you may get some instability in the joint. The synovial fluid, which is very thick and viscous in a normal joint, becomes much more like water. Now it gets actually overproduced by the synovium, but it becomes more like water, so you have less of a lubricant inside the joint. The other thing is you get synovial thickening, so the synovium, which is nice and thin in a normal joint, gets really thick and it's irritated, and it starts overproducing the synovial fluid, but it doesn't give the normal synovial fluid. You also get bone spurs that develop, so you just can see that there's a lot of damage that occurs within the synovial joint as arthritis progresses. And then symptom-wise, I mean, the primary symptom that people feel, and there's a lot of symptoms, is pain. And what happens is you get pain, you avoid moving the joint. That increases muscle tightness, and you get limitation of motion. Well, then that circles back and you get more pain. So if anyone's ever been in to see me as a patient, I talk about arthritis as a downward spiral. You get this inflammation, you get pain, and it just keeps going because you can't, not a lot of people learn how to stop that or how to treat the arthritis. And I think this is an important slide, knowing that, as you get pain, there are also other factors that lead back to more pain. So what we can do in our treatment is not only block the pain, but if we can move the joint, if we can improve muscle stability, if we can improve muscle strength, if we can improve, maintain your range of motion, it'll do a lot to break that cycle, that downward spiral of arthritis. So again, just to go over it, we talk about a chronic condition that gradually worsens over time. There's nothing that we can do at this point to fix arthritis. It's going to progress. In mild arthritis, you're going to get the surface of the cartilage begins to wear down. Mild arthritis, you get mild stiffness. You may, be getting up in the morning and say, "Oh, my knee is stiff," and then as you walk along, it gets better. In moderate arthritis, you continue to get more joint wearing away. And as that joint wears away, you get spur formation, you get muscle tightness, you get bursal inflammation, and moving becomes more painful. So initially, you might get morning stiffness, occasional pain, then that pain becomes worse, you get that. So we can see how that downward spiral develops. And as you get severe arthritis, the cartilage may totally wear away, and the bones are now rubbing together, and it becomes painful daily activity. You can't walk without pain. You sit, you have pain. Sleeping, you have pain. And a lot of times, we tend to see patients all along this continuum, and the thing that always surprises me is that no matter how far the progression is with arthritis, some people have no pain, and some people with mild arthritis have severe pain. So you can't always go by how severe it is on x-ray or on an arthroscopy, because everyone is different. I like to tell this story. When I had been in practice probably 3 months, I had an 82-year-old gentleman come into my office. And what you can get is changes in the bone, and we'll see that as we go along. You get changes in the architecture of the bone. You can get bow-legged or knock-kneed. He was bow-legged with thought, and he walked in and he just wanted to know why his knees had a mild ache after he walked 5 miles a day. And his knee x-rays were just completely shot. Everything was gone. So again, you've got to put it all together. You can't, because some people then will do a knee replacement or we've done knee replacements on some people. We get into the knee, you're like, wow, there's not a lot of arthritis here, but the knee replacement helps them. So it's sort of a catch-22 because you can go by a lot of this, but you've got to, also put the symptoms and the pain. And then we'll talk about the symptoms as we go along. So again, arthritis in detail, and I know I'm going over this a lot, but I think it'll help you to understand sort of what goes on and why you get arthritis. And sometimes we don't know why. But again, you've got the normal joint here. You're starting to get the mild changes of osteoarthritis. You get the cartilage loss. You start getting cysts in the bone, the inflammation of the synovium. The fluid starts to get less and less. And then as you get on, it just keeps going. You get more bone spurs. You get thickening of the synovium, and you just get continued wear and tear changes on the joint. And everyone can go. You might come in with this and have, again, I know I'm sort of beating a dead horse. You might come in with mild changes and have significant pain, come in with this and have no pain. Now, I've had plenty of stories where someone said, I was doing fine, I bent over to pick up my grandson, and boom, my knee started hurting. They come in and they have significant arthritis, and they've been able to deal with it for all those years. So now the prevalence of arthritis, and that's what really gets me, is how many people suffer with arthritis and arthritis pain. So osteoarthritis, as you said, is the most common form of joint disease. 50% of people of 65 years of age will have x-ray evidence of arthritis. And 80% of the age of 75. And 12% of people over the age of 60 have symptomatic osteoarthritis in the knees. And then 27 million people. Well, that's 27 million people that we need to help because it affects, it affects your job, it affects your home, it affects your quality of life. And if we could do something to help that. And again, it's a burden across, it's 44 million care visits, 20 million people with limitation, 992,000 hospitalizations, 128 billion in total costs. Not that we want to look at obviously monetarily, but there's just, it's a widespread condition that I've sort of made this my little project now, is trying to help people through non-operative arthritis care. Because I think if we can help that, then we're limiting how much knee replacement. Not that those aren't treatment options, because those are treatment options. But I think if we can get to people earlier, we'll delay the need for that. And I'm not saying that there's no need for that, because there is definitely need for that. But I think if we can, so now, what do we talk? We talk about risk factors. Risk factors. Who might be more at risk for developing arthritis? And we can break those down into sort of biomechanical, biochemical, demographic, also what I like to call modifiable and non-modifiable risk factors. Modifiable means those you can change. Non-modifiable means you can't change it. So if we get, if we talk about age, unfortunately the older we get, the joints wear out. We can't do anything about that. Genetics, there is a genetic factor in arthritis. If someone in your family, if a primary family member has had arthritis, you're at an increased risk for osteoarthritis. But other factors, obesity, being overweight, not being as fit, all that, because it is a simple analogy, but if you imagine someone who's 5'2" and 100 pounds, that's another person 5'2" and 200 pounds, that 200-pound person is putting so much more wear and tear through their joints. So that is a big risk factor. The other thing is trauma. If you've injured your knee, we lose the ability to regrow cartilage or to fix cartilage on our own body by the age of about 20, which is amazing. We can't fix cartilage. So if you're at the age of 22 and you really ding up that cartilage, it won't heal itself, so you can get earlier onset arthritis. In fact, I saw a 40-year-old gentleman today with end-stage arthritis because he injured his knee 20 years ago. Or a bunch of treatments that will get you out of pain. And it's not just, take a couple Advil and then, we'll see if that helps. There's a lot of things that we do nowadays to help, and mostly there's two types of I try to break them down to sort of two types of treatments. One being lifestyle modifications. What can you do to change, to help yourself? And then medical treatment. What can we do through medications, shots, different things to help the arthritis pain? And they sort of go hand in hand. They're not two separate treatments, but there's treatments that we'll give you to do, and then treatments that we can do. So when we talk about lifestyle modification, there's a lot of different things that you can do. There's weight loss. So we talked about, there's you can lose 20 to 30% of your body weight. You're going to take that pressure off your joints. Every time you step, you put 2 to 3 times your body weight through the joint. So I go back to that similar thing we said, that person who's 5'2", 100 pounds, compared to 5'2", 200 pounds, they're putting less weight on their joints. And some of that is through a nutrition. Understanding the proper foods to eat, understanding where to get the proper foods. Then an exercise program. Well, some people come in and say, you know what, it hurts to exercise. So there's a double-edged sword right there. Okay, I understand I need to exercise, but if I can't walk or if I can't, how can I take care of my pain? So that's where we have physical therapy. In physical therapy, we'll get into is having a therapist work with you to teach you the proper exercise to do so they don't hurt, but also giving you some pain relief ideas so that it'll help with the stiffness of the pain. There's range of motion exercises, so we want to maintain that range of motion. There's low impact, so in exercise for arthritis, you don't want to be a runner. You don't want to go out and become a marathoner as your form of exercise, because that impact can accelerate the progression of yoga. We've seen some benefits of yoga, and I'll get into that. And at some point, we talk about maybe bracing, some canes and walkers and different techniques if it gets so severe that you can't, have sort of a stepwise process.
Sure. I noticed on the slide back, one of the exercises you had was biking, and I was told that biking is not necessarily good for an arthritic knee. Especially if you're close to bone on bone.
No, I think it's a perfectly fine exercise. Absolutely. Stationary biking maybe more than road biking. Okay. Because if you're gonna, if you gotta go up a hill, I'm gonna have to pump up easy. Stationary biking will help. It keeps that range of motion. It keeps the muscle strength. I mean, all of it is again based on symptoms. If it hurts to, we don't want you to, but it's better than other forms of exercise. So again, nutrition. We talk about more weight puts more pressure on your joints, and extra body fat increases inflammation in the body. So certain things you can plan your diet around inflammation-fighting foods, and they actually have been found that foods rich in omega-3 fatty acids may help reduce bodily inflammation, not just for arthritis, but for different inflammation. So foods such as fish, walnuts, flaxseed oil, olive oil. Now, salmon was the #1 fish. I did do some when I researched it, they said that salmon was the #1. Protein-rich foods. That's another thing. It helps with muscle mass. As we get older, we just lose our muscle mass. It's much harder to build muscle. It's much harder to maintain muscle. So having protein-rich foods can help you to maintain that muscle mass. And fruits and vegetables. I didn't find the studies, but vegetarian-based diets may alleviate symptoms of arthritis. Now, I think the majority of that is because maybe if you're eating more vegetables, more fruits, you're on a healthier diet, you've got that lifestyle modification, maybe you're taking weight off to help the pressure on the joints. But again, it's sort of a global treatment for osteoarthritis. It's not just, take Tylenol. And I think this is important. And everyone's going to do things differently, but this is sort of a global treatment and sort of program. Now, physical therapy. Physical therapy is that goal where you're going to reduce the pain, swelling, and stiffness. And by doing that, you're going to improve knee joint function, make it easier to bend, kneel, squat, and sit. And you do this under the guidance of a physical therapist or physical therapist assistant in a practice where they're going to give you two different, because, as I said, you come in, I can't exercise, it hurts. I can't do it, it just hurts. I've tried to do it. and they'll teach you different things. They'll do different types of treatment. They may do passive treatments, where they're actually doing the treatment. They do range of motion exercises, where because it hurts you to do the motion, they'll do the motion. What we call passive or active assist range of motion. And then there's active, where you do the work. You come in, you learn the exercises, and just like when you were in high school, college, you go home and do the homework. So they sort of serve as your teachers. And we've seen a lot. We do this in conjunction with a lot of our treatments, whether it's medicine treatment or injections. We like to get patients into physical therapy. And I'll come in and I'll say, and I do have patients that they do not want to do physical therapy. And I won't push them, but I do try to say, you know what, if we can improve your range of motion, if we can improve the muscle strength and improve your strength, it'll take away the pain. So, common passive treatments. Now these are all oftentimes things you can do at home as well, but cold therapy, so ice, that can, what it does, reduce the circulation and decrease the swelling, and swelling is a symptom of arthritis, so the symptoms that you're feeling. Heat therapy before an exercise also sometimes helps with inflammation because it brings blood flow to the area and decreases stiffness and improves muscle function around the joint. So oftentimes you'll come in, have a heat treatment before you do your physical therapy, gets your joints all loosened. They'll do the therapy, and then you can ice. So that's oftentimes what they'll then have you do at home. I know that some people who have thumb arthritis actually use, it's here, they use a paraffin bath where they'll actually put their hand in hot wax. It's on this side. And it'll actually, that heat will help alleviate symptoms. The other thing is aquatic therapy. Not only aquatic therapy, but there are aquatic classes. I think Synergy and probably I think I've seen at the Y that they have aquatic classes where you can go in and exercise in the pool. That fluid medium is wonderful for, if it's a warm pool, it's great because it helps lubricate the joint, but you can move your joints through full range of motion. It doesn't hurt. Some people, even walking hurts or biking hurts, and you've got to find that exercise.
Can I ask you a question?
Sure.
When do you know to use either cold therapy or heat therapy?
My general rule of thumb is before exercise, heat, after exercise, ice, and then whatever feels good. If your primary symptoms, swelling, if your joint swells, then I typically say ice, because that's going to reduce swelling. If it's pain or if it's stiffness, then I say heat, because heat will help to bring blood flow to that area, help lubricate it, and help warm it up. So I think it's based more on symptoms. I have some people that swear by ice. I have some people that swear by heat, no matter what the problem is.
Okay, thank you.
Does that help? And in active treatments, these are the ones where the physical therapist will teach the exercises, and then obviously at some point therapy wants to then have you doing the exercises at home. So strengthening exercises, working out the muscles in the leg helps make your knee stronger, and strengthening alone can help decrease the pain, because if you strengthen the muscles, they take the pressure, not the joint. So we oftentimes, after surgery, we'll actually have a patient, this machine right here actually it tests, it's an objective measurement of strength, and we have patients go through, and I haven't done it with arthritic patients, but I may start doing it because they hurt, but they actually will measure their muscle strength. And you can actually tell in someone who's more symptomatic that they're going to have a weaker muscle. If you ever look at one side, there's a reciprocal reflex in your body that if a joint's inflamed or if it's painful, it sends signals into the muscles of your body to shut down because they want to protect it. So that's part of that downward spiral where we talk about that pain and avoidance of motion. And avoidance of motion is part of that, the body's weakness. So if you can build up the strength, sometimes that's enough to take care of the pain. Sometimes you don't need medication, or you can get off anti-inflammatories, not need injections. And then flexibility exercises increases the range of motion and resumes normal function. I get a lot of people come and say, I can't bend my knee beyond here because it hurts. And then again, over time, they've stopped moving it, so it hurts. And they can't move it anymore. So getting into therapy, gently stretching out the knee will help to restore the normal knee function, but not only that, it increases the amount of area that the pressure goes to. So instead of maybe just one, if your knee's only moving this far, that's not, you've got just one little area that's getting all that pressure, but all that motion increases the amount of pressure, it distributes pressure more evenly throughout the joint. So these are just, some. The other thing that we're learning more about, even not only with arthritis, but with ankle injuries, with knee injuries, is that how important exercising the core is, everything. Exercising your back, your abdomen, having a strong core can lead to improvement in arthritic pain. So these are just some examples, and Eric was nice enough to put them together as a handout on some of the symptoms of arthritis, and then some gentle exercises, some simple exercises you can do on your own at home. And again, some stretching exercises, some gentle, some people, we talked about exercise. Exercise is an important treatment in osteoarthritis, and it's a lot, I think if patients and people can understand that keeping your weight down, muscle strong, it really helps slow the progression down. It slows down that progression of the disease and maybe prolongs before you need to have something done. Maybe you don't have to have something done. But again, non-weight-bearing exercise is better because it keeps the stress off your joints. And strength training is also important, keeping the muscles strong. And again, you want to learn those different ways to exercise. So if you want to start an exercise program, and we have here, we have physical therapy. We also have something called Access Acceleration, and it's physical therapists, athletic trainers who can teach you the proper ways to exercise so that you don't hurt yourself. Because that sometimes you say, well, I tried to start exercising, but it hurt. I tried to go out for a run, but I couldn't do it. Well, if you have arthritis, you don't want to be running. Or I tried to walk up hills, and walking up hills might make the symptoms worse, depending on where your arthritis is. So I think proper exercise, learning how to do it, is what is important. Not only wanting to exercise, but learning the correct way to do it. So there's just a few things. There's strength training. There's strength training that you can do that does the whole body. We have fitness classes. We have different core strengthening classes where it's just your body weight that helps to exercise. Water aerobics, we talked about, getting in the pool. Not only does that heat help, but you can strengthen. There's that fluid medium that the resistance that the water gives you is enough sometimes to build your strength. Walking is good. Cycling, again, we talked about if cycling hurts, but I think even with bone-on-bone changes, doing some light cycling, you're not going to be getting up and climbing the Mount Washington race, but even like a hybrid bike or something that's not, you don't have to work as hard with sometimes. Or just having a bicycle built for two and having one person do work.
How about the recumbent bikes?
Very good. Very good, absolutely. Those are good for people with back pain, good for people with osteoarthritis of their backs, absolutely hip pain, because they can certainly give you that aerobic conditioning, but sometimes more comfortable. Now again, I put this in here, and it's funny, we have a yoga instructor here. She had to grab some water. I do yoga, and I found that my joints and my overall being is much better with yoga. And it's, everyone's like, oh, I can't do yoga. Anyone can do yoga. And it's a practice. It's mental, physical, and spiritual unity, but basically, knee pain is heightened by being sedentary. If you sit, if you can't get up and exercise, it's that downward spiral that we keep talking about. Get up and just doing something, gentle motions, will decrease the pain. And it's another way of increasing muscle strength and stability. And sometimes, it stimulates that knee's cartilage. You get up and move around, and the blood flows to that area, and you get. And there's also spiritual benefits of yoga. There's emotional benefits. So, if you're in pain, if you're hurting, you don't want to exercise, it's emotional. There's emotional factors involved in yoga, psychological factors. You can't go out skiing with your buddies anymore. You can't, you can't go and take the walk with your grandkids that you want to because it hurts. You can't get out as much. There's a lot of factors, not only just your pain from arthritis. It affects, you can't work in your shop, you can't go up and down stairs like you want to. So yoga actually, can improve the psychological effects. And again, I do it and I feel much better. And I'm not just promoting, I do actually do it. I was going to have our yoga instructor take some pictures of me doing yoga, but I figured that was way too much for this talk. But again, some of the poses with yoga will hurt. So if you do decide, if that's part of your, and again, your goal tonight is to, think about how do you, if you do have arthritis, how do you want to treat it? How do you, some people don't want to exercise. They want to look for other treatments. Some people don't want medications. They want to do exercise. So yoga is just another form of treatment. But do make sure that you have a yoga instructor that's certified. And then, again, that they can provide, you tell them when you start a class, I have, arthritis in my knees, so you don't want to be getting down into deep squatting positions or some of those positions that hurt. So, and these were just, this is actually from Johns Hopkins. These were some of the poses that they recommended doing for those with osteoarthritis, because they don't necessarily put a lot of strain on the knee. They're building core strength, but they don't put a lot of strain. You're not going into deep knee positions. You're not spending a lot of time with an aggravated knee. Because, even though this is deep knee bend, it's not a weight-bearing pose. So you can do non-weight-bearing poses that are strengthening if they don't put pressure on your knees. I'm not going to spend a lot of time on assistance and braces, but there are different. If you get to the point where just walking is painful because the joint is destruct, the joint gets so far gone that the ligaments are loose and you don't feel stable. There are certain, walking with a cane can certainly help. Different assistive devices. There's different types of cane. There's a 4-prong cane that as you get older and your balance is a well, you can use, and even some of these rolling carts. We have a lot of patients that come in with the rolling carts that help them because walking is painful. Here is what we call an unloader brace. And sometimes if you have arthritis in one compartment, they can, so if your knee, if your arthritis is here, mainly in your knee, they can crank the brace so it takes the pressure off that part of the knee and puts it on the other side. I don't use a lot of them. I've used them occasionally, but they tend to be cumbersome and painful, and I don't see a lot of patients liking the unloader braces. Some people, but again, if you don't want to have surgery, if things aren't working, there's that option as well. Sometimes orthotics in shoes, arch supports. Someone with flat feet. If you're walking with flat feet, that changes the architecture through your knee joints and can help, by giving a little bit of an arch may change the forces through your knees. Now we're sort of getting into this medical management, supplements and medicines. There's a lot of treatments out there. There's sharp cartilage. There's I can't remember some of these, but the biggest supplement I get asked about is glucosamine and chondroitin. Glucosamine is actually it's become popular in the last several years. And glucosamine is a normal building block in joint cartilage. And the thought is that if you take glucosamine, it can help regenerate healthy cartilage. I have yet to see any objective data that it works. I've seen subjective data where patients take it and they say, yeah, it helps my knees, or it helps my wrists, it helps my thumbs. And it's a naturally occurring substance, and you don't have to, it doesn't really interact with much in your body. There's not a lot of side effects, so it is pretty safe to take. But I'm not sure how it works. And I don't think anyone's really been shown. They've done studies where, yes, a patient takes, maybe they take an anti-inflammatory, a placebo, and glucosamine. And they take it for a couple months, and they're asked, how do you feel? And yes, the glucosamine chondroitin subjects have shown to be as effective as some low-dose anti-inflammatories. Not necessarily prescription strength anti-inflammatories, but low doses of Advil.
I actually just read that in a clinical trial, glucosamine showed slight improvement, measurable but not congruent.
Yeah. Well, they say to take it together.
Yeah, and that
but
didn't show.
It didn't show. Yeah. And again, there's studies across the board. I Googled it. And there's so many different products, there's so many. The one thing that we typically say is if you're going to take it, make sure that you're getting 1,500 milligrams of glucosamine, 1,200 of chondroitin daily. That's what has been shown to possibly give some improvement.
What's the effective difference between glucosamine, chondroitin, and fish oil?
I don't know. I think
Is there any
that's...
benefit to one versus the other?
No, not that I've seen. The only thing is, I think that if you take this for, the one thing that I think with any supplement, if you take it for a couple months. Take it for 2 to 3 months. If it helps, then continue on it. And this is what I've said for 15 years. If it doesn't help, after 2 to 3 months, you should notice a difference. I think you're just spending money. Now, yeah, fish oil, there's been studies of neurologic that help with that. But as far as joint pain goes along, kind of like shark cartilage, I'm trying to think there was some other stuff a few years ago that people had asked me about. I've never seen where any of it objectively works. Subjectively, yes. I mean, even in tests with medications where people are taking anti-inflammatories, people take placebo. Some of the placebo patients are getting improvement. And why is that? I think it's because it's something in the brain that stimulates that they're getting better. So the one product that we do promote is cosamine DS. If you're going to take that, it's just been shown. I think it's the more pure. It's one that has been shown to have some. I don't get any money from cosamine DS. That's one thing that I've seen throughout. It has the equal amounts of glucosamine, chondroitin, and is sold in pharmacies and health food stores. It's not sold. So that's sort of my spiel on glucosamine and chondroitin, is that if you want to take it, absolutely. It hasn't shown to have many side effects, but if it doesn't help, if you're not seeing improvement in 2 to 3 months, I would stop taking it. But again, I have some people that come and say, well, I've tried glucosamine and I'm taking naproxen, and so I think it's working. So I don't know. I mean, I can't say, well, maybe it is working, but it's maybe the naproxen that's working as well. So how do we manage it? How do us as providers manage it? So I've sort of shown you how, maybe as a patient, you can manage it. It used to be sort of this pyramid. Like, you get a diagnosis of arthritis, we try and start you on simple analgesics like Tylenol. Then we work up to over-the-counter or anti-inflammatories like Advil, Alleviate, Motrin. And then we work towards NSAIDs, so like naproxen, Voltaren, and then Celebrex, which is some of the newer. And then we talk about injections, talk about surgery. Well, you can't do that with everybody. You can't say, okay, Mr. Jones, you have liver disease, you can't take this, how do we do it? It's more across the board rather than up and down. Because you have some people that are going to do very well with Tylenol, and that's all they want to take. Whereas other people are going to want a cortisone shot. They're going to want something more definitive. They come to me, they've already tried Tylenol, they've already tried arthritis medication. They don't want it. Okay, you've tried ibuprofen, I want to put you on something stronger. People don't necessarily, and there's side effects associated with some of those as well. So I think every patient is different as to when they come in to see us. So it's become more of a side-to-side shift than an up-and-down shift. So initially, over-the-counter anti-inflammatories, you have Tylenol. So Tylenol is acetaminophen. Usually we say no more than 1,000 milligrams every 6 hours. You don't want to take more than about 3,000 to 4,000 milligrams of Tylenol a day. It's been shown to be a little bit better than placebo, but it's not an anti-inflammatory, it's a pain medication. It's not acting on the inflammation, it's acting on the pain. But in patients that are on multiple medications, on patients who might be on Coumadin or can't take anti-inflammatories, Tylenol is a good option. But people who have liver disease, whether it's cirrhosis, hepatitis, you don't want them on Tylenol because it's filtered through the liver and it can cause more damage. You have anti-inflammatories, so over-the-counter anti-inflammatories, so moderate, and again, indication, moderate to severe pain have failed acetaminophen. Well, I get a lot of patients that have tried Tylenol, they've tried over-the-counter anti-inflammatories. And the one thing about anti-inflammatories is there is about, I could name 7 off the top of my head because not one works for everybody. There's Voltaren. Well, I got one person on Voltaren, I got one person on Celebrex, and one person on Motrin that I saw, or Mobic that I saw today. Because one works for somebody, it's highly variable across patients, depending on how how the concentrations are in your body or how your body works. And then there are what we call the COX-2 inhibitors. Well, anti-inflammatories work by blocking an enzyme that produces inflammation. That enzyme is also protects your, it's in your kidneys, it also protects the stomach lining. So for people who were taking chronic anti-inflammatories, the biggest, not only were their liver and kidney problems, but bleeding ulcers, bleeding problems that developed. So they came up with a COX-2 here. I heard of Vioxx. That was a COX-2 many years ago. That was found to have cardiac problems. There's Celebrex, which is the newest, which is sort of you probably see ads for that, and that's a pretty safe medication to take. But some people don't want to be on medication. They don't want to take. My typical thing is I don't like to keep patients on medication for long periods of time. If you come in, it's hurting. Yeah, if it's been an acute flare-up, I'll put you on it for maybe a month. But I want you to come off of it and try to stay off it, because I think sometimes side effects are worse than the treatment, and you've got to weigh that. So I might have, I have a 40-year-old gentleman I saw earlier today. Yeah, he doesn't have any problem taking an anti-inflammatory. But the 87-year-old woman who's on multiple medications but can't get along because she's got osteoarthritis, I don't want to put any more medication into that system. I don't think that's fair. So we've gotten, so this is sort of where injections come in. We can do injections, so the medication management or the medical management, the medicines are acting, you take them orally and then they're not acting locally. You might take down the inflammation area. The injection therapies act locally. So there's 2 types of injections that we'll do. There's cortisone, which most people know, and that's a potent anti-inflammatory that you put inside the joint to help reduce inflammation. And sometimes the indication is pain persisting despite oral analgesics. My indication is I've got someone who comes in, they've got an acute flare-up, it's hurting, they want something that's going to act quickly and they don't want to take pills. I may give them a cortisone shot. But cortisone is also limited. You don't want to do more than about 3, I don't do more than 3 in a weight-bearing joint. There's been some indication that maybe more than 3 speeds along the degenerative process. Cortisone shots can hurt. The injection can hurt, but it can actually, you can get what's called a steroid flare, where for the first 48 hours, you don't like me very much. I don't see it as much in knees as I might with wrists and hands and elbows, but there is definitely an acute pain indication. But it's a good option for, I've had, again, patients that come in that have an acute flare-up, they haven't had pain before. And I'll give them a cortisone injection, I don't see them for 3 years. But some people keep coming back in and I will do 3, but I don't want to do more because I just don't think, it's also been shown, research has shown that it reduces effectiveness with repetitive injections. The first injection may be 80 to 90% effective, the second one probably 60%, third one probably 40%. So, so the newest injections is called hyaluronic acid, and it's called viscosupplementation. It's a big, long word. Remember how before we were talking about all the changes that occur in a joint with osteoarthritis? Well, if we can replenish that dried up or that watery synovial fluid with healthy, almost normal synovial fluid through injection therapy, it's been shown to give real good relief. So what it is And again, pain persists despite other agents. Sometimes I'm using this right away. And it's a synthetic, so your synovial fluid is made up of hyaluronic acid. And hyaluronic acid is what really helps to make normal healthy joint. That hyaluronic acid and that synovial fluid is thick, it's viscous, it's helping to cushion the joint. In an arthritic knee, it's doing nothing. It's being overproduced, but it's more like water, so you don't have anything to help lubricate it. So basically what we're doing is we're putting through injection therapy, putting back that fluid into the joint, creating a cushion, but also research has shown that it maybe tricks the joint into saying, oh, we're more of a normal joint, and start producing more normal joint fluid so you can get good long-term relief. There's a lot of different products out there. There's Synvisc, there's Hyalgan, we happen to use Euflexa in our office mainly because of patient satisfaction and safety. But it's a series of injections, and it's not a medication. It's not doing anything to alter a chemical process in your body, so it's safe. It's safe, so we can put it in the 40-year-old jogger or the 89-year-old patient with multiple medical problems. So it's a very safe and effective. It's 3 injections given over a 3-week period, and the pain relief has been similar to steroid injections, but it's been longer term. I have several patients that have 6 to 8 months of relief with shots. I've had a few people that get 3 to 4 years of relief with shots. And it can be repeated as well. You can repeat it every 6 months if needed. So it's a safe and effective management. And again, Euflexa is the one that we use here. The main reason why, because Euflexa has been shown to be safe. The way that the whole hyaluronic acid and viscosupplementation developed is that they found that hyaluronic acid was very, very big concentration in rooster combs. So initially, rooster combs were it's a bigger process, comb, ground down and made into the Euflexa. I'm sorry, not Euflexa, I apologize. Into the supplements, into the viscosupplementation. Well, they found that with some of that, there were side effects. There were some safety issues, or maybe people were developing allergic reactions. So Euflexa is actually a bioengineered product. So we use that. It's much more safe than some of the others. How's it given? Well, we just said it's 3 weekly injections over a 2-week period. So if you Tuesday, simply you come in, give you the shot, and we say for 48 hours we don't want you to exercise, we want you to take it easy, and then after the 3rd injection you start feeling relief. And again, there's no side effects, so you can stay on your Coumadin, don't have to stop any medications like you might have to before surgery, and it can be repeated. So that just, again, I share it because, I share the Cosamine because that's what I found to work. We use the Euflexa here in our office. And again, is it covered by insurance? That's a lot of people's question. It is covered by insurance.
How long has that been on the market, this kind of concept?
It's been on the market for a while, about 10 years. And there's different products, there's different injection series. There's a series of 5 injections. There's one product that's a 1 injection, and then there's the Euflexa, which is the 3 injections. We use it because compared to the injection where there's the 1 injection, that's been shown to actually have a 2% chance of what we call a pseudoseptic reaction, where it just blows up like a balloon. Not that it happens a lot, but you don't want to be that person that it happens to. And I've had that happen 4 or 5 times in 10 years. I haven't had that happen with Euflexa at all. So